Good morning. This is Mark Arnold, Senior Vice President of Marketing with Zap Surgical. Welcome and thanks to everyone for joining us today for our 6th webinar as part of the fall SRS webinar series. This fall lineup does include 11 talks over 11 weeks. So if you haven't already, I encourage everyone to visit the fall.srs-webinars.com website to review the future talks that we have in store for you. And through this website, you can also register to view recordings of prior webinars as well. One item of business before we get started: if you'd like to submit any typewritten questions at any point during today's talk, you can do so by using the Q&A button at the bottom of the Zoom console. And time permitting, Dr. Chang will take your questions at the end of this presentation. So without further delay, I'd like to introduce today's moderator, Dr. John Adler. Dr. Adler is the CEO and co-founder of Zap Surgical, inventor of the CyberKnife, and Professor Emeritus of Neurosurgery and Radiation Oncology at Stanford University. Dr. Adler, over to you.
Thanks, Mark, and welcome everyone this morning. It's a pleasure to be introducing Steve Chang. Steve is a friend and colleague and someone who I've known throughout so much of my professional career. Is currently chaired professor, the Palo Professor of Neurosurgery in the Department of Neurosurgery and at Stanford, and probably more than anybody else, in many ways more than me, responsible for building at Stanford one of the largest radiosurgery programs, if not the largest radiosurgery program in the United States. And he's done this just methodically through the years, and they treat just a plethora of different conditions. And the one that we're going to be talking about today, pre-op and post-op radiosurgery for brain metastasis, was in large part a procedure that came out of Stanford. So I think Steve has lots to teach us, and I hope you all enjoy what he's about to lecture on. So welcome, and Steve, take it away.
Okay, thanks, John. Okay, so welcome everybody this morning, and appreciate everybody's time and carving out some of your busy day to spend with us. Just going to talk today about an overview of pre-op versus post-op radiosurgery for brain metastasis. And the goal of the presentation is to discuss the rationale for pre-op radiosurgery for brain metastasis, discuss the relevant literature. There's some cases out there, but as a relatively newer technique in radiosurgery, it's limited to a few key papers. So we'll go over those and then discuss the possible issues that can come up with pre-op radiosurgery. One of the things that we'll see at the end of this talk is that once I go through the relevant literature, there's a lot of focus on, for example, the timing between the pre-op radiosurgery treatment and the surgical resection, but there's not a lot of time spent on other factors that would input the throughput and flow. So we'll talk a little bit about that. So the post-op radiosurgery has been around for decades, and it started as a treatment option to avoid the neurocognitive sequelae of whole brain radiation. And I remember in the early 1990s when I first started working with John, there was a pretty rigid cutoff of no more than 3 metastases, and if you had 1 to 3 metastases, you could be treated with radiosurgery. And obviously, over the years, we've pushed that envelope. Now patients with many metastases are treated with radiosurgery, in large part to avoid the consequences of whole brain radiation. And this has largely come about because the medical oncologists have become better and better at treating the systemic disease, and patients are living a lot longer. So the neurocognitive issues that were not significant problems when the average survival of a patient with a newly diagnosed stage 4 cancer was not very long have now become a significant problem. But we did notice that in post-operative radiosurgery patients, there were some patients that started developing leptomeningeal disease, and we first started noticing this at Stanford with breast metastasis patients, fairly high recurrence. And at least in our data at Stanford, it was about 40% of patients that had surgery followed by post-op radiosurgery started to develop this leptomeningeal disease. And it also seemed to be more prevalent in infratentorial locations as well. Furthermore, we know that what our protocol has been at Stanford for over 10 years is to add a 2 mm margin, and our group led by Dr. Scott Soltis has published papers showing that this 2 mm margin is necessary to achieve good results. But as a result of this, adding this 2 mm margin, you're essentially increasing the three-dimensional volume. So a 1 centimeter residual cavity, if you add a 2 mm margin, you effectively almost doubled the radiosurgical volume. So it's possible that these patients are at higher risk for radiation necrosis because of this increased volume. We also know that intact tumors prior to resection, there's clearly a better margin that's visible in the scan. So you got a better chance of outlining the target. We also know that postoperative surgical beds are hypoxic and potentially less responsive to radiation, and that's in addition to potentially not being able to visualize the margin is clear. So the concept of using pre-op radiosurgery may allow a more well-defined margin, potentially with lower volumes, lower doses, and this may be a benefit for some of the patients. So I want to talk about one table here, then we'll jump into the literature. So this is came out of Routman and his team and was published just a couple of years ago. And they had a nice table talking about the potential advantages and disadvantages of preoperative stereotactic radiosurgery compared to postoperative radiosurgery. And they're just listed here. We can talk briefly about each one. So under advantages, increased local control, we mentioned that there can be a better ability to target the tumor. We talked about the lower chance of leptomeningeal disease, lower radiation necrosis in large part because of a lower volume. And then they talked about increased systemic control, talking about improving the time to getting to systemic therapy. I don't know if I personally agree that this is a significant advantage, at least not in our experience at Stanford, just because the timeline of doing a pre-op radiosurgery followed by surgery versus surgery and then post-op radiosurgery is actually not different. And then under disadvantages, they brought up three. First was this lack of pathologic confirmation prior to radiosurgery. And we'll see in one of the pieces of literature we're going to talk about. And this wasn't a high probability, but roughly 1% of patients ended up with pathology that was different than expected. We know that pre-op radiosurgery is not compatible with emergent surgery. As for the surgeons in the group, obviously if you're admitting a patient on the weekend that's in extreme neurologic distress, you're not going to be doing radiosurgery pre-op. And then there's a theoretical issue with wound healing. I'm not sure if I agree with it, that's a big issue. I've not really seen that in our practice, but that was discussed as a possible disadvantage. So the first paper that really started talking about radiosurgery prior to surgical resection came from Asher and his group, and this was published in the Red Journal in 2014. They looked at a total of 47 patients, including 51 brain metastases that were treated, and they had roughly a target of 24 hours pre-op radiosurgery versus surgical resection in terms of the timeline in between. Their average follow-up was 12 months. And you can see here the diameter was about 3 centimeters. So these were presumably some of the more larger symptomatic tumors. And the median dose they used was 14 gray to the 80% isodose line. We can see on the local control, fairly good numbers. At 6, 12, and 24 months, we see 98, 96, and 72%. I think the 96% at 12 months is great, actually. And we'll see some of the other papers, as the volumes get larger, that number starts to drop. And overall survival, you can see, is 78 and 60% at 6 and 12 months. They had identified some parameters which showed when tumors were more likely to fail this regimen, and that were larger volumes in terms of cubic centimeters, larger diameter tumors, dural proximity, and finally, eloquent location. And that may somewhat be in part secondary to the more conservative surgical resection rather than a result of the radiosurgery. And 14.8%, roughly 1 in 6 patients, had to be treated with whole brain radiation after this regimen for either recurrence or additional metastases. Patel and his group published in the Neurosurgery Journal in 2016 their series. There's 2 institutions that had a total of 180 patients. They had a median of about 48 hours between radiosurgery and surgical resection. And their 180 patients were divided to 1/3 getting pre-op radiosurgery and 2/3 getting post-op radiosurgery. And so they kind of did a comparison between these 2 groups. You can see the groups were comparative with the exception of what's listed below. I think the key differences were that there was a lower marginal dose with the pre-op radiosurgery of 14.5 gray versus 18, and they obviously had a smaller margin of 0 versus 2 millimeters. What they noticed is that in these 2 groups, the group that had post-op radiosurgery had a higher chance of leptomeningeal disease at the 2-year mark. It was 16% versus 3%. Wasn't quite statistically significant, but indicated a possible strong trend. And the same thing with radiation necrosis. They had a lower radiation necrosis rate in the pre-radiosurgery group. The comparable rates of long-term control were noted between the 2 groups. So in Dr. Adler's Journal Curious in 2017, there was a paper. This was a relatively smaller group. They had only about 20 patients, but they all underwent pre-op radiosurgery. You can see the tumor volumes and the target doses are 14 and 18 gray respectively. And this was a collection of patients treated across multiple radiosurgical systems, Novalis, CyberKnife, and Gamma Knife. Surgical resection, we're still looking at the 24 to 48 hour range. Their follow-up was limited to just 6 months. And they did have local recurrence in about 10% of the patients. They hypothesized that the responses due to this protocol of pre-op radiosurgery were due to improved vascularization that was preserved, easier tumor outlining during treatment planning, and reduction of seeding from potentially irradiated cells. If you seeded the cells at the time of surgery, it didn't matter because you'd already irradiated them. Then the next important paper came out in 2018 in World Neurosurgery. Again, a relatively small group, and you'll see this because across the papers I'm going to present, they're not a very large series, but this group had 12 larger maximum tumor diameters. So we're getting close to 3.7 centimeters. So compared to Asher's paper, these volumes are about 75% larger than his original paper. So starting to push the envelope there. The dose is a little bit higher, 16 gray, and you can see the conformality index of 1.2. No difference here between the timing between radiosurgery and surgical resection, still looking at about 24 hours, and they had a median follow-up of 13 months. Local control, lower than Asher's paper, only 81% at 6 months and 49% at 12 months. And you compare that to Asher's paper, he was sitting at about 95% at 12 months. But this may be in large part due to that these were, again, larger tumors, about 75 to 80% larger volume than Asher's series. They also had a handful of patients that developed leptomeningeal disease after radiosurgery. They didn't have any radiation necrosis. So in terms of variables that they identified as associated with failure were larger tumor volumes and diameters and posterior fossa location. This paper came out in Journal of Neurosurgery in 2019. Larger number of patients, 117 with 125 brain metastases. You can see the breakdown of the histopathology. Almost half were lung cancer, and then about 20% were breast and melanoma. Gross total resection achieved in 95%. The average time, again, between radiosurgery and surgery was about 24 hours. And you're starting to see a pattern here in terms of the dosing. It's kind of sitting around 14, 15 gray shown here. So at the 2-year mark, only less than 5% had leptomeningeal disease, 5% had symptomatic radiation necrosis. Local recurrence at 2 years was 25%. And this is actually almost exactly the same number as that first paper by Asher. They had about a 25% local recurrence at the 2-year mark. They identified 6 patients that had a subtotal resection of the tumor, and those patients were associated with a higher risk of local recurrence and worse overall survival. This is an important paper. Perhaps I think if you're going to read one paper out of all the ones that I'm talking about today, this is probably the one that should be read. It's a review. It's a very nice review. It's by a group of authors over multiple institutions, and essentially it looked at a lot of the literature to date regarding this topic of pre-op radiosurgery. They pointed out a couple of things. They talked about the change in volume. So adding a 2 mm margin, if you did the post-op radiosurgery to the resection cavity, increased the target volume by over 50%. They commented how if a patient has surgery first, maybe they need time to recover, they might need to go to rehab for a few weeks. And so the median time between surgery and their post-op radiosurgery in their review was 4 to 5 weeks. Seems a little bit longer than our experience at Stanford, but that's what they were noticing in the literature. And so during this period of time, that you could have systemic disease progression. You could start to have a recurrence of the disease locally if there was an incomplete resection. So that was an issue. They certainly noticed that post-op radiosurgery was associated with higher rates of leptomeningeal disease than what was reported in the literature for whole brain radiation. And again, the theory was due to tumor dissemination at the time of surgery, potentially along the resection track. And then we'll talk about how one of the risk factors is proximity to resection, with most of the leptomeningeal disease occurring within 5 centimeters of the actual resection cavity. There was a pretty robust discussion of the postoperative surgical bed and having hypoxia and therefore not responding as well to the radiation doses. They then addressed pre-op radiosurgery, talked about the advantages here, so let's briefly discuss them. The first comment mentioned was that they felt there was increased patient compliance of undergoing the surgery. In other words, that if you got the patient into radiosurgery and they agreed to this plan, that there was a high probability of the patient completing surgery, and that certainly it's above 90% in terms of the series that did report it. When you deliver the radiation to an intact tumor bed, it's more favorable for the radiation based upon the oxygenation, which leads to induced DNA damage. So the argument is that you can actually use lower doses than you can in post-op radiosurgery. There was a discussion of immunotherapy. Higher doses of radiation therapy, appears to increase surface tumor antigen expression. This results in a higher presentation of sequestered tumor antigens and a more robust immune response in patients that are on immune checkpoint inhibitors. So there was a a nice review in this paper about things. So again, if there's one paper to take home from this presentation today to read, this would be the one that you should focus on. The last paper I want to review before we kind of shift gears a little bit is this paper that came out just a year ago. And it nicely summed up the current rationale for doing pre-op radiosurgery. And we've kind of mentioned all these, but let's go through the list again. The first was reducing leptomeningeal disease. This was the paper that commented on the fact that most leptomeningeal disease occurred within 5 centimeters of the tumor resection site. And the risk factors were breast primary, piecemeal resection of the tumor, a large tumor volume larger tumor volumes associated with higher chance of leptomeningeal disease and a posterior fossa location. The issue of contouring we've talked about, and it was, again, you can better identify the tumor margins pre-radiosurgery and avoids adding the 2 millimeter margin in the post radiosurgery patients. Radiation necrosis, we know clearly it's related to dose and volume, and if you can reduce both dose and volume, you're likely to get less radiation necrosis. Post-treatment complications here, the comment was made that post-op morbidity occurred in 20% of patients, which thus delayed post-op radiosurgery. I think that number might be a little bit high, but that's what was discussed here. They talk about minimal barriers from pre-op radiosurgery to operative resection. And then I think you'll see across all these papers that's the variable that everybody's focused on. How much time is it going to be between pre-op radiosurgery and surgical resection? Nobody's talking about any other the time frames, and we'll talk about that in the next slide. And logistics of post-op radiosurgery. They talk about inability to define tumor cavities very well, and making it more difficult to do the post-op radiosurgery. And then lastly, again, we've talked about the tumor radiobiology there. So to summarize, the issues with respect to pre-op radiosurgery, the concerns were, is there going to be an issue with wound healing if you do the radiation first? That didn't seem to be the case. In terms of change in management plans, there were almost 2% of patients, a very small number, that had the radiosurgery and then something happened, they never made it to the surgery. And then finally, histopathologic curveballs. I mentioned about 1% of patients went in getting their pre-op radiosurgery with the thinking that they had a certain pathology, and then during the surgical resection, you found something else. So the main advantages of the pre-op radiosurgery are reduced radiation necrosis, smaller volume, lower doses, and the lower chance of leptomeningeal disease. And I'm going to spend just the last 2 slides talking about the issues with pre-op radiosurgery that I've experienced that I think were not really touched on or really glossed over in terms of the literature. And the first issue is this, is that surgery, as a neurosurgeon, we think about the larger brain metastases needing the surgery. And the largest of these tumors, the most symptomatic of the tumors, are the ones that can't wait for radiosurgery. So probably the patients that have the highest need for surgical indication are the ones that are the worst patients for this regimen of doing pre-op radiosurgery. If the patients are hospitalized or they're symptomatic, you're not going to be able to either delay their surgery if you're going to do the pre-op radiosurgery, or if your radiosurgery program is in an outpatient setting, being able to discharge the patient can be problematic. So this is a not insignificant number of patients. So of the brain metastasis that we treat at Stanford, I would say close to half of the operative patients are either transferred in or admitted to the emergency room, and therefore going to be inpatients at the time of the decision making. And we'll talk about that issue in the next slide. The second issue is an issue that I didn't see really kind of discussed in any of the papers, and that is this issue. I think those of us that do a lot of radiosurgery have all had this experience where there was a patient with a relatively large metastasis, probably would be considered for surgical resection. However, the patient had significant comorbidities and, not a candidate for anesthesia. Yet we did the radiosurgery, just upfront radiosurgery, thinking, oh, it's better than nothing. They're not operative candidate. Let's do the radiosurgery. The tumor's large. And some of these patients surprise us. They come back with their next scan a month later and the tumor's dramatically smaller. But had they been an operative candidate, they would have certainly had the surgery. So I think this number is much more significant than we realize. So one of the issues with this regimen of pre-op radiosurgery followed by surgery is I think you're committing a lot of patients to surgical resection that would not have necessarily needed surgery if you just did the radiosurgery up front and followed them. And then the last issue is this timeline. Every paper that we reviewed today talked about 12 hours or 24 hours or maximum 48 hours between pre-op radiosurgery and surgery. There was kind of no discussion of the timeline prior to the pre-op radiosurgery. And in my experience, this timeline, if the patient's, and let's talk about two scenarios, inpatient and outpatient. If they're an inpatient, you can try to expedite the radiosurgery. You're keeping the patient hospitalized for a number of days while you're particularly if you're doing multiple fractions because they have many tumors. And in my experiences, insurance companies have now started to catch on to this, and we've started to see some denials now where the insurance companies are refusing to pay for inpatient pre-op radiosurgery just because they think you're hospitalizing the patient for a procedure that doesn't require hospitalization. So that's a big issue if you're an inpatient. Now, if you're an outpatient, you don't have that issue, but depending on the patient's insurance, getting authorization for radiosurgery in an outpatient setting doesn't happen in 12 hours typically. And so you can have a delay, and I've seen delays as long as a week waiting for authorization for pre-op radiosurgery. So this concept of the pre-op radiosurgery followed by the surgery saving time, I'm not sure if that's exactly the case. If you have a patient that's an inpatient that needs surgery, it's not if you put your mind to it, you can get the surgery done and have the patient post-op in 6 to 12 hours from the time of admission. There's no way you're going to be able to coordinate a pre-op radiosurgery that quickly. So I think that the point I'm trying to make here is that I think the target population in terms of which patients would be optimal for this, I don't think has been well defined based upon this timeline and scheduling, and based upon the fact that a number of these larger tumors, I think, could probably just get away with radiosurgery alone without the surgical resection. So with that, I'd like to conclude, and I'd be happy to answer any questions. Thank you.
Thank you, Steve. I'm opening up the floor now for some questions. A couple questions from the audience, and the first here, Steve, is when treating with pre-op radiosurgery, what is your experience with delayed surgery, i.e. happening between days 3 and 7 post-radiosurgery rather than within 24, 48 hours? And you touched on this a little, but so here, delayed surgery versus near immediate surgery in the first 24, 48 hours.
That's a good question. I think the patients that fall into that delayed surgery category, in my experience, are pretty much not typically the patients where we plan to do the pre-op radiosurgery followed by surgical resection. They're typically the patients that we were maybe planning on doing radiosurgery alone, and we did it, and maybe they had pre-radiosurgery edema that got worse, they got symptomatic, they ended up in the ER and then needed a resection. So Certainly the ones where we've done this planned regimen, I think we have a lot more control of the time. Obviously, when you plan to do both, you have the surgical dates scheduled when you do the radiosurgery, so I think these delayed resections, in my experience, have been these kind of more unplanned cases.
Right. Okay. And so another question is, what about fractionated radiosurgery rather than single fraction in the neoadjuvant pre-op situation?
Good question. I think depending on, I think that decision is going to be largely dependent upon, size and volume. We know that we can give lower doses with the pre-op radiosurgery, so perhaps that might reduce the number of fractions. The only problem I see with these multiple fraction cases, and this is kind of what I alluded to in the last set of slides, is if you have a patient as an inpatient and you are trying to get the radiosurgery done prior to doing the surgery, these multiple fraction treatments really start to raise the eyebrows of the insurance companies.
Right.
If you need a patient that needs, let's say 3 fractions, and you're starting on Thursday, so now you have a Thursday, Friday, you're likely delivering the 3rd fraction on a Monday. The patient's now been hospitalized for 5 days before they finish their radiosurgery. And then when you start adding on, a 24-hour turnaround to surgery plus 3 days in the hospital after surgery, you're really hospitalizing the patient for 10 days. Sometimes to get this done. And as I said, we've had.
Well, does it need to be a daily fractionation regimen?
Well, that's
in the old days we used to
fractionate. I don't think there's
intervals.
Yeah, I don't think there's the data there. I mean,
Sure.
We have the series are all small there, but certainly we don't know.
Yeah, sometimes we just lapse into what we're comfortable with, and I don't blame the insurance companies for pushing back. Hey, so question: is your dosing for pre-op radiosurgery based on tumor size, or is it a uniform dose for all? I think you touched on that a little, but we didn't get too into it. So how does your dosing vary across tumors, different types of different pathologies, and tumor size?
So I think it's pretty similar to the patients that are not going to undergo post radiosurgery resection, and I think you sort of have to plan it that way because some of these patients may not end up with surgery. So I think the radiosurgery has to be somewhat of a definitive treatment, because if the patient doesn't end up going to the operating room for whatever reason, you need to have at least enough of a dose in there that's going to give you some reasonable control. So I think knowing what we know about the volume and the biology of the various tumor types, I think you have to dose it accordingly. I don't think you can underdose banking on a surgical resection.
I'm curious because you have an interesting population of patients. How often do you see such dramatic disappearance of edema and symptoms that you just change course? Is that, you kind of allude to a couple cases like this, but has this been studied systematically in any way? Because I'm particularly interested in the oncologic effects of radiation, and one of them might be, edema. And do you see just spontaneous or near spontaneous remission after a single action of radiation and just suddenly has totally transformed the course of the treatment? Or are people so on a train of events here, once they sign up to this, it's kind of, written in stone that they will get their resection? My question makes sense?
Yes, yeah, and I think that was the concern that I was trying to emphasize in the second to last slide here is, so the scenario, probably, it's not very common, but the scenario is, you have a patient, you're planning on doing let's say the radiosurgery followed by surgery, or, they're, again, I use an example, they're too sick to get the surgery. So you do the radiosurgery kind of as as a last ditch effort. And the patient comes back and you're just surprised at how much the tumor shrunk and how much the edema resolved. I don't think we understand which patients those are going to end up in. And I think it's certainly a valid concern that whatever number of the percentage those patients are, and we don't know what they are, but if you're committing them all up front to surgery, you will certainly be operating on patients that might not need a surgical resection. And in the series that we talked about, some of the series presented just cubic volumes, but some presented diameters. So if your median diameter is 3 centimeters, you're certainly treating some patients under 3 centimeters. And does a 2 centimeter tumor with some edema in an asymptomatic patient really need a resection 24 hours after radiosurgery? Or can you follow them and then resect them if they get into trouble?
Can I suggest an interesting study? Not that I'm going to do the hard work. Just get at the time that they get treatment plan for radiosurgery, have a sequence that shows, edema, and then repeat the same sequence at the time for image-guided surgery. And it would be fascinating to see just if there's a cohort of patients in 24, 48 hours who have a dramatic remission in their edema. And ultimately, it is edema that kind of forces all of us to do surgery up front. Because I mean, they're probably, you point out quite, kind of avidly here, is that there's a cohort of patients who don't need this, who don't need resection. And yet we don't seem to be on a path to learning who those patients are without a little more study.
Right. I definitely agree with that. And, I think the patients I would be concerned about are, let's say, a patient goes on this regimen of pre-op radiosurgery followed by surgery, ends up getting the surgery, perhaps unnecessarily. Maybe they were one of those patients that could have got through this. They get the surgery and then have a postoperative complication.
Yeah,
it's pretty significant morbidity. And then you're in a situation where you created a problem that potentially could have been avoided. So I think a little bit concerned about committing everybody to this protocol if it without some kind of independent thought to whether the patients actually need it. I mean, maybe it needs to, there should be some, consideration to, doing the radiosurgery, and then, if there's certain parameters in place, then do the surgery. If other parameters are not in place, then watch those patients. I mean, surgeons are usually pretty quick about being able to get a patient to the OR if they get into trouble. So I'm not too worried about a patient getting lost for a month and herniating from brain edema. But I think that the number of patients that potentially don't need the surgery is a fairly significant chunk of the patients that we're looking at here.
Would you ever do neoadjuvant radiosurgery on an outpatient basis and then bring the patient into the hospital? You implied what I thought, that everyone comes in the hospital, gets their neoadjuvant radiosurgery, gets their surgery. But what about outpatient, changing from an outpatient status to inpatient status, or is that too dangerous, do you think?
No, I think actually in our experience, probably slightly more than half of the patients that we've done this at Stanford were outpatients for their radiosurgery, and then got admitted. What I have noticed is that as an outpatient, your ability to get insurance cleared for their radiosurgery is substantially longer. I would say from the timeline from decision making to radiosurgery in terms of processing all insurance and setting up patient, getting them transported and things like that, if they need that, typically can be, I would say on the average of 3 to 5 days. Whereas if they're an inpatient, you can bring them down for simulation right now.
Gotcha.
So I think there's pros and cons of each approach. What I have noticed, if you try to admit them to do the radiosurgery, you're going to get a lot of pushback from insurance. You're going to end up doing a lot of free radiosurgery because they won't reimburse you.
Well, as is so often the case, insurance decision-making drives clinical decision-making. Okay. Well, if there are no other questions, I'm going to thank you, Steve, very much for doing this. It's a kind of a fast emerging and I know I've learned something this morning, and I hope everyone else has as well. So thank you, and everyone stay safe. Be well. Thanks, Steve. Bye-bye.